and welcome, please, Dr. Howard Kirshner.
I'm going to a general update on stroke, including how you diagnose it, what you can do to treat it, and what you can do to prevent it. I understand there weren't quite enough handouts. I sent handouts that were voluminous. A stroke is a sudden loss of brain function, so sudden onset of a neurologic deficit. Most of them are due to a blockage in the circulation, so not enough blood gets to a part of the brain, and that's called ischemic. They rob the body or the other types of deficits. So I know you all heard a talk about Alzheimer's disease not long ago by my friend and colleague Bill Petrie. That's a disease where you lose function slowly, gradually. Stroke is rather different in that it's a start out almost 800,000 every year in the United States. There's one stroke every 40 seconds in the United States, a fatal stroke every 3 minutes. MRI scans in older people, but it's estimated that roughly 11 million people have silent strokes. They're actually them. Immediate disability, but down the road it can contribute to memory loss, dementia, and so on. So I think when we talk about prevention, we need to prevent all the forms of stroke. Now, in the past year, stroke has gone from being the third leading cause of death in the United States to the fourth because chronic lung disease is getting more common. I guess that's a good thing that we're slightly. Worldwide, stroke is number 2 in, and remember that it mainly causes people who have a stroke survive, but they survive somewhat different from the way they were before. And there are almost 6 million people in the US who have disability from strokes. There are some risk groups in the population. Men outnumber women, except for very elderly women. There are more women around in their 80s and 90s than men. African Americans have about twice the risk of stroke as Caucasians. Latinos are somewhere in between. Everybody knows that being elderly is a risk factor. Most people think this only happens to elderly people, but that's not true, of course. About a third of strokes occur before age 65, and they occur throughout the age range. The most important point that I will make in this whole talk this morning, so if there's one take-home point, it's that most strokes are preventable, but we'll come back to that one later. This slide shows you a geographic disparity in stroke, that people in the southeast part of the United States have between 1.5 and 2 times as many, these are mortality stroke data, so have almost twice as many fatal strokes as people in most of the rest of the country. And if I had more time and could ask for volunteers from the audience, I'm sure you could all tell me some reasons why strokes are more common in the South. You know, it has to do somewhat with diet and somewhat with salt in your food and fried food and lack of exercise and prevalence of smoking and so on. But the experts say that those known factors account for about half of it, and there are other risk factors that we don't fully understand. So it's an area of research. Now, when we talk about acute stroke treatment, the point to make is that time is brain. I know the cardiologists talk about time is life. If you're having a heart attack, you can save your life by getting to the hospital quickly. Again, most strokes don't cause death, but they do cause damage to brain tissue And it's estimated that every minute after a stroke starts, there are almost 2 million neurons or brain cells dying. So time is of the essence. So can we treat a stroke? I would again say prevention is the best treatment. We're always starting from a big disadvantage when we try to treat a stroke patient after the stroke has started. But we do have acute stroke treatments. The modern era started in 1996 with a drug called TPA, or tissue thromboplastin activator, which can be given by an intravenous infusion. It's a clot dissolver or a clot buster. And more recently, we've had interventional treatments where an interventional neuroradiologist or neurosurgeon or even neurologist goes in with a catheter and tries to disrupt a clot. So I'll show you some pictures of that. The TPA era started with a study that was in the New England Journal of Medicine, and I'll just run through it briefly. It involved 600 patients who were randomized to TPA or placebo treatment, all within 3 hours of the onset of symptoms. So you had to identify the patient, make sure they really had a stroke, you had to do a CAT scan, you had to do some blood testing. So it takes a good hour usually from the time the patient arrives in the emergency department to the time that the drug is running. So that means we're on a rapid schedule. But you can see there 30% more patients who were given the treatment got to a level of minimal or no disability, which is what we want. Patients that might notice in themselves that they've had a stroke, but nobody else in the room would notice. Able to go back to work or go back to hobbies or whatever he or she was doing. Stated in another statistical way, the odds ratio of a good outcome is 1.7 to 1. It's not 2 to 1 quite, but it's 1.7 to 1. Now, the downside of giving this drug is that it can cause bleeding. So how often did that happen? 6% in the treated patients, less than 1% in the non-treated patients. So it raises your risk of a brain hemorrhage by 10 times. But despite that, how many people die? It trends lower in people given the TPA treatment. So you're not more likely to die. You're a little bit less likely to die. I don't know if I have a pointer, but if you look at, there are 4 curves here because there were 4 outcome measures. If you look at the third one, which is modified Rankin scale, and again, 0 or 1 means either no disability at all or a slight abnormality that a physician could pick up but that doesn't really interfere with function. And you can see there that 26% got there with placebo and 39% got there with treatment. So that's where the 30% comes from. 30% more people do this. Notice you don't see more deaths, you don't see more severe disabilities, maybe a few more, and not much difference in moderate disability. So it shifts the curve in the right direction. Now this is the same set of information showing time. At what time is the patient treated? And this study was unique in that they had 2 windows, a 90-minute and a 180-minute. So half the patients were treated within 90 minutes. And you can see here, if you were treated within 60 minutes, which is barely possible, your odds ratio isn't 1.7, it's almost 4. So almost 4 times more likely to recover. If you do it at 180 minutes, it's just barely better than placebo. So what that means is that time is of the essence. So if the patient shows up at 1 hour, we don't take our time getting them evaluated and treat them right at 3 hours. We treat them as soon as we can. Now, I don't want to go into detail on this, but there was a study in Europe more recently where patients were treated up to 4.5 hours, between 3 and 4.5 hours. And they had these exclusions, which I'm not going to go into in detail, but it just means, if there are any physicians in the audience, I know there's at least one, you can't use the exact same criteria that you use for the NIH score or what the FDA has mandated. The FDA actually hasn't weighed in on this, so you're using it off-label if you do this. So we rigorously use these criteria. And the results were that, again, there was a better outcome in treatment. The bleeding rate was slightly higher, 7.9% instead of 6.4%. But again, mortality trended lower. So where do we stand with this? It's not FDA approved. It is endorsed by the American Heart Association, which issues guidelines on stroke treatment. It's a gray area, but at Vanderbilt we do it. Now, what about people who don't qualify for the intravenous thrombolytic therapy? We can call in our colleagues. At Vanderbilt right now, we have 2 neurosurgeons and 1 neuroradiologist. And they put a catheter up. They can give TPA through this catheter, or they can use one of these devices. And this is a better picture of the first device that came on the market. It's called the Mercy device. The first version of it looked like a little corkscrew. So you thread it up and you try to snare the clot on the corkscrew and then pull it out again. The newer device is called the Penumbra, and it's really a series of suction catheters, and then if you encounter a hard clot that doesn't want to come out with suction, they have this little mesh that will ensnare it also and pull it out. And Penumbra, the odds of opening the artery are better. So most of our colleagues are using this device. There's a newer one yet that's coming that I'll mention a little bit later. I thought I'd say a word or two about imaging. We do CT scans, which tend not to show an acute stroke. So CT by itself is not as useful. It does rule out a hemorrhage. With MRI technology, we can do better, except that it's not right by the emergency department and it takes longer to do the scan. But this is a diffusion-weighted MRI, and you're actually seeing the area of stroke damage there. This is an MR perfusion, which is a research tool. We don't use this on every patient. But basically, you give a timed infusion of a contrast agent, and you map out where it goes in the brain, and it's color-coded for the amount of perfusion. So if the perfusion is below the limit for tissue viability, that means the brain tissue is going to die, and it shows up red. And this agrees rather well with the area of damage. If it's green, it means there's reduced flow. So for our interventional colleagues, you stop on the red and you go on the green. If it's all red, you're probably not going to help the patient. If there's a lot of green, you have something to do. Yes?
You're using some terms that I don't understand, perfusion, and I mean, I could guess at them, but would you mind telling us what they mean?
Yeah, please stop me if I speak over people's heads. Perfusion just means blood flow, the amount of blood flow to the brain. And what was the recanalization means you open the artery up again. I'll show you a picture of that. So I was going to present one case. I was looking to see if he was here this morning, but he is a 71-year-old man. He did give me permission to show this. In fact, he came to our stroke symposium in November and gave a talk himself, and he said it much better than I can, but I'll do my best. 71-year-old man, previously healthy, except he did have mild hypertension, and he had intermittent atrial fibrillation. Now, for the physicians in the group, an irregular heartbeat or atrial fibrillation is a very high risk factor for stroke, and most of the time we treat it. Now, in this case, he was not treated because his Vanderbilt cardiologist, who is an extreme expert on the subject, felt that he was low risk. And I could go into more detail about that. We'll come to AFib later. So he went to bed at 10 o'clock on the night of July 8th, was normal then. That's the last time he was seen normal. At 1:20 in the morning, he went to the bathroom, and on the way back, he fell. He was having weakness in his left arm and leg. And his wife tried to talk him into calling 911, and he said, no, just help me back in the bed. I'll be all right. He says now he wasn't able to think clearly at that moment. he was probably neglecting his deficit on the left side of his body. And she finally got him to agree, called 911. He got to the emergency room at 3:27, and a code stroke was called. On examination, he had a bad left hemiparesis. He couldn't move his left arm or left leg. He had a left face droop, and his speech was slurred. So significant stroke. He was beyond the TPA window, right? He was last seen normal at 10 p.m. This was 3:30 in the morning. So we couldn't give him IV TPA. So we called our interventional colleague, Dr. Connors. We do it, a lot of times we do a CT, yes, ma'am.
Excuse me, how do you know he wasn't normal at 10:30?
Well, no, we don't know, but the point is you take the last time they were known to be normal.
Then you add 3 hours to that.
Right. Or even 4.5, maybe. So this is called a CT angiogram. It's a CAT scan, but you're putting dye in the blood vessels through the venous system. And this is the middle cerebral artery. On this side, it stops, but then you do see the branches distally. So either this is artifact, it's just going out of the plane of where you're imaging, or it's really blocked, but he has good collateral. I think the latter was true. This is a CT perfusion, similar to the MR perfusion I showed you, but we can get this faster in the emergency department. So this is just blood flow, and you can see this darker color means there's less blood flow in the right frontal lobe. This is another color-coded perfusion scan, like the MR one I showed you, where red means there's should be damage, and green means there's not enough blood flow, but the tissue can still be saved. So based on that, he had an angiogram, and he has an unusual anatomy in that his middle cerebral has 2 branches right from the beginning. Usually the artery goes for a centimeter, half an inch or so, and then splits into branches. But his branched right away, and he's got clot in both branches. So you're not seeing the artery fill fully. This is after treatment, and they are filling fully. So Dr. Connors went in, used the penumbra device, gave some intraarterial TPA, very small amount, was able to get the arteries open. And this is his MRI after the fact. And he does have some damage, but it's relatively limited. His clinical course was great. I mean, he was immediately improved. He had a little bit of facial droop, but no left arm or leg weakness. We thought he might be feeling more normal than he really was, but he actually proved to us he passed his driving evaluation, he went back to work, and he's doing fine today. He's now on an anticoagulant for his atrial fibrillation. So the stroke meetings were last week in New Orleans, and there's a new set of devices called stent retrievers, where it's a plastic stent that opens up the artery, and then you can grab the clot out and remove the whole thing. Those look better yet than the previous devices. They're not yet on the market in the US, but they will be soon. I pointed out, I think, in presenting this case, how important the imaging is. And in fact, we're getting to the point where we can make an educated guess about how long the stroke was, to answer that last question. How do we know? Well, this might be a better way to know. If you don't see damage on the CT scan, you see hypoperfusion, perhaps you can go in even not knowing for sure, like a wake-up stroke, for example. Okay, I'm going to shift gears again and talk about transient ischemic attacks. These are the warning signs of stroke. So they're the same symptoms as the symptoms of a stroke, but they go away. And I think one of the important messages this morning should be that everybody should know what the warning signs of stroke are. And these are the 5 that the American Heart Association talks about. The first one is sudden loss of vision, especially in one eye, like a shade dropping over one eye. A lot of people don't even think to mention that to a doctor. The second one is difficulty speaking or understanding language. The third one is weakness or numbness on one side of the body. I think most people recognize that one. Now, these three are all symptoms in the anterior circulation or carotid artery system. The fourth one is dizziness. Sometimes the Heart Association just says dizziness. Dizziness, 9 times out of 10, is not a stroke. It's an inner ear problem or something of the like. So dizziness accompanied by balance difficulty or staggering, trouble walking, that is a worrisome symptom of a stroke in the posterior circulation. And then the last one is sudden severe headache, and that one really is a separate topic. It relates to ruptured aneurysm. A ruptured aneurysm presents with a sudden headache, like no other headache you've ever had, worst headache of your life, often accompanied by a stiff neck. And sudden meaning thunderclap-like. So that is a warning sign for ruptured aneurysm. But any of those symptoms should lead a person to go to the emergency room. So what happens to a person who's had a transient ischemic attack? This is about 10 years old, 12 years old even, 2000. This was from Northern California, Kaiser Permanente system, where they didn't admit people to the hospital who had TIAs. And about 10% of them had a stroke. But notice the rapid drop-off here. About half of the strokes occurred in the first 2 days, 48 hours. So the conclusion from this study was that TIA is an emergency, that we shouldn't be sending people home. In the US, we tend to admit them to the hospital overnight. We call it observation, 23-hour observation. They're not charged for a hospital room. Now, in the UK, in England, they're doing a similar study, Oxfordshire, England, and they came up with this ABCD score, later modified to ABCD2 or squared. I don't think I'll go into all the points on this just to save time, but you can stratify patients as to who's at the highest risk. And certainly if you have 3 or more points here, you're at high risk. If you're over 60, if you have high blood pressure, if you have weakness on one side, if you have speech difficulty, if it lasts more than a few minutes, and if you have diabetes, you get points for all of those. In England, they set up what they call a clinic. It's more like our observation admission, but they're not admitted to a hospital. They do it outpatient. And what do? They put them on a heart monitor, they do a regular EKG, they do an echocardiogram, they do carotid imaging, fasting lipid profile for cholesterol, and a glucose for diabetes. And they treat everything they can treat. When they set this up, this is before they set up the clinic, this is after, was the incidence of stroke in 90 days after the patient was evaluated. So before they set up the clinic, it was about 10% had a stroke. After they set up the clinic, it was about 2%. So that's pretty impressive. You can reduce the risk of stroke. If there's statisticians in the group, the relative risk reduction is 80%. The absolute risk reduction is 8%. That means of every 100 people having a TIA, you'll prevent 8 strokes if you set up an emergency evaluation system. So the rest of the time I'm going to talk about prevention of stroke. It applies to people that have had a TIA, it applies to people that have had a stroke, and to some extent it applies to all of us in the room who haven't had a stroke. Yes, sir.
Before you change subject,
Sure.
if you have a TIA and you go to the hospital and they hold you overnight, what is it they're doing there? It's treating
Okay.
you. I understand they're monitoring, waiting to see if something happens. And if nothing happens, I assume they let you go, but they don't treat you, do they?
Did everybody hear the question? It was, what do we actually do when we evaluate the patient? So I mentioned the diagnostic tests. We do an image of the brain, usually an MRI, and an image of the arteries, which can be done various ways, MRA, CTA, Doppler. So we look for narrowings in the arteries going to the brain. We do an echocardiogram looking for a problem in the heart that would throw a clot. We do EKG monitoring for atrial fibrillation. And then we do some blood tests, a fasting lipid profile and a hemoglobin A1C for diabetes. And as far as what we do for treatment, we put everybody on at least aspirin. In that England study, they use aspirin and clopidogrel, Plavix. We don't do that in this country. We could talk about that as a separate issue. If we find a carotid lesion, we call in a surgeon, and I'm going to present about that. And if we find atrial fib or a source of embolus in the heart, we use an anticoagulant. Those are the main treatments. But the point is getting them on treatment right away, not after outpatient tests are done a week later.
I have another question about something you've already discussed. You said the stent retriever devices were not available in the U.S. yet. Where are they available? What countries are ahead of us?
Oh, I think Europe.
Europe?
But now there was a North American trial that was presented last week. And I actually wasn't there. I was here on call. But I understand they looked at their data a different way. It was good outcome without hemorrhage. And it was, I think, between 60 and 70% with that device, and it was about 25% with the Mercy device.
Are we just more cautious in this country?
Oh, well, we have an FDA that's very cautious, I would say. Although historically they approve devices more easily than they approve medications. That's another talk. I think you were next.
For TIA, the symptoms, in order to determine if you have a TIA, it's the same as stroke.
Right.
It just happens to be a TIA that you discover this when you get to the hospital. Is that right? I mean, how
Well,
do you know if you have a TIA?
Right. I mean, if you do exactly what I just said, you'd go to the hospital as soon as it happens. So you wouldn't know at that point if it's a stroke or a TIA.
It's the same symptoms.
The symptoms are the same. The question was about symptoms of TIA and stroke. They are the same, but in TIA, by definition, it goes completely away. The time definition is 24 hours, but most of them last a few minutes. Lucia? Yeah. Okay. Okay, one quick one, and then we'll.
You said about neurons dying and the number of cells. How many neurons do F, A, and B? Do neurons regenerate?
Those are good questions. I think the number of neurons is 14 billion. And do they regenerate? Generally, if they die, they don't regenerate. Now, there's a question of whether there exist stem cells in the central nervous system. There are some stem cells. We used to think there weren't. But the problem is they don't succeed very well getting where they need to go to establish new connections. But that is another whole subject, whether stem cell science will lead to treatments that can restore brain tissue after strokes. We don't have that yet, but it is something that's being studied. So the risk factors for stroke now, there are more of those than there are warning signs. So the biggest single one is high blood pressure, hypertension. And I'll talk about that. Hyperlipidemia or high cholesterol is another one. Diabetes is a big risk factor. Smoking, I'm going to talk about each of those. Obstructive sleep apnea I'm not going to talk about, so I'll just mention if anyone has it. These are people that snore and have interrupted breathing, especially men, middle-aged and elderly men. And they do have a higher risk of heart attack and stroke. It's an independent risk factor. So if you or a loved one has it, it's worth getting it checked into. Exercise is important. I asked Jeanette Norden, who I think has given talks in this course many times, if she had any advice for me. She said, tell them to exercise. Exercise not only prevents stroke, but it prevents heart attack, and it even seems to delay aging changes and Alzheimer's disease. So if there's one thing you can do to prevent yourself from getting old and demented, it's exercise. And one of the best sources of evidence, by the way, was the New England Nurses Study, where nurses who exercised did much better with regard to stroke than nurses who didn't. So atrial fibrillation I'll come back to. I'll talk about carotid procedures and anticoagulation, and then I'll end up with the antiplatelet medications. So this slide I owe to a colleague, Phil Gorelick, a stroke neurologist in Michigan. These are just 5 risk factors. if we could control these 5 risk factors, so if you could get everybody to treat their blood pressure to normal, treat their cholesterol to normal, stop smoking, either get out of atrial fibrillation or go on a blood thinner, and stop drinking too much. Those 5 risk factors, if you could eliminate them, you would prevent most of the strokes. I mean, hypertension alone, you'd prevent half of the strokes. So I always make the point that stroke is not the same as cancer. We're not waiting for a scientific breakthrough. We really know how to prevent stroke. The problem is we have not been effective enough at getting the message out. So opportunities like today are very important for stroke specialists like me. And secondly, the public needs to understand the reasons to adhere to the recommendations their doctors make. Okay, so hypertension. 1 in 3 people in the United States has hypertension. That's the latest survey. It used to be 1 in 4 as recently as 5 years ago. It has to do with the obesity epidemic in the country. And if you have high blood pressure, your risk of stroke is about 5 to 6 times what it is if you don't have high blood pressure. Now this is a study, I'm not going to go into a lot of clinical trials, but this is people that had had a stroke, or TIA, were treated with an active regimen using 2 drugs, an ACE inhibitor and a diuretic. You don't have to pay attention to that, but versus placebo, it just shows that you could prevent about 28% of the strokes over a 4-year period. In primary prevention, probably even better. You can probably prevent half of the strokes, 40 to 50%. So I would say, this is my own editorial comment, that control of blood pressure is more important than which specific drug you use to get there, though. What numbers? Well, what numbers is not a simple question. In the US, the definition of hypertension is a systolic over 140 or a diastolic over 90. So if you're above that, you have hypertension. But if you're below that, you're in pre-hypertension unless you have below 130 systolic and below 80 diastolic. So pre-hypertension, there's some increased risk. So the effect is linear all the way down into the normal range. So the best blood pressure is the lowest one that you can tolerate without getting dizzy when you stand up. And there is a lot of controversy about which drugs are best, and I'm not going to go into that. What about cholesterol? Well, historically, this one was not talked about as much in stroke. Stroke and heart disease and peripheral vascular disease have a lot of things in common, but there are some differences. And one major difference is that hypertension is more closely linked to stroke, and cholesterol is more closely linked to heart disease. However, in studies of people with heart attacks, they prevent, if you are treated with a statin drug. Does everybody know what a statin drug is? It's a drug that blocks the synthesis of cholesterol, basically. HMG-CoA reductase inhibitor. There's drugs like Lipitor and Zocor and Pravachol. There are a bunch of them on the market now. And those drugs have been shown to prevent stroke. Other lipid-lowering drugs really have not. So most of what I'm talking about has to do with statin drugs. So if you have a heart attack and you get put on a statin, it also reduces the risk of stroke. And we now know that if you have a stroke and you go on statin, I'm going to show you one slide from a stroke study that we were part of at Vanderbilt called the SPARCL study. So these were people who had a stroke or TIA, and they had a LDL, that's a bad cholesterol, of over 100, between 100 and 190. They were randomized. This Atorvastatin is Lipitor, 80 milligrams, or placebo. Took a while. It's a little different from the hypertension curve, where you start preventing stroke right away. The cholesterol drugs, it takes about 2 years before they're really separating. But you do see a benefit preventing stroke. So we now do put people on statins. What about diabetes? Well, there's a lot of information on diabetes. I think the most important point is that if you have diabetes, you're already at increased risk of both heart attack and stroke. So the goals for controlling your blood pressure and your cholesterol are lower than for the average person. That's the first point. We think that if you control your sugar well, that also helps. But that's been more complicated to prove, and there's also some evidence that if you control it too well and you get hypoglycemic spells, that has adverse consequences and even increased death. So our goal is to keep the diabetes relatively well controlled, hemoglobin A1C below 7. But be sure to keep blood pressure under this number and LDL cholesterol under that number. Some people would even say if you've had heart disease or stroke, the LDL should be under 70. Okay, what about smoking? Any smokers in the audience? See, nobody's admitting to it. Everybody that comes to a lecture like this is already health conscious, so I'm preaching to the converted. But if you smoke, your risk of stroke is almost 3 times what it is if you don't smoke. If you stop smoking, your risk goes down to baseline in about 3 to 4 years. That's from observational studies. I think the message for us as stroke doctors is we have to get to work on this right away in the hospital. It's a very teachable moment when someone has just had an event. And we offer treatment with one of these things. Okay, now then it gets more complicated. How do you prevent another stroke? It depends what the cause of the stroke is. So I'm showing you here a classification of stroke, which is probably more than you need to know. But on the left is hemorrhages. This is a hemorrhage in the brain, so-called intracerebral hemorrhage. It's a type of stroke. It's the worst type. It's the most likely to be fatal. It's very, very preventable. It's almost entirely caused by high blood pressure. This is a so-called subarachnoid hemorrhage where the blood is not in the brain. It's around the brain. And that's caused by a ruptured aneurysm. This is a stroke caused by a problem in the carotid artery. So we call it large vessel atherothrombotic stroke. This is a small vessel stroke in the brainstem, a little softening in the brainstem. This is showing a clot that came from the heart that lodges in an artery in the brain. That's an embolic stroke. And this means either we don't know what caused it or it's another cause that's less common that I'm not going to have time to go into. So how do we treat these people? This is all prevention. This one we can think about surgical procedures. This one we do blood thinners, anticoagulants. But everybody, in both groups, we do risk factor modification. And in this, and this group, we do antiplatelet therapy. So that's in a nutshell. So I'm going to say, how's my time doing? Carotid disease, a few points. This is an angiogram showing a carotid stenosis right there. This is what the surgeon sees, scrapes out of the artery. It's a fatty plaque with an ulcer in it. I think of that picture whenever I'm tempted to have another slice of pizza or or a cheeseburger. That's what happens to your arteries. Now, I think I don't want to run out of time. These are clinical trials just showing that carotid surgery, this is when all we had was surgery, is better than medical treatment. Quite a bit better. I don't think that's a debated point anymore. This is kind of putting the surgical trials in a nutshell. If you have symptomatic, so you have a TIA or a stroke, and you have greater than 70% narrowing in your carotid artery, this 8.5% is an absolute risk reduction per year for the first 2 years. So the risk was 26% without surgery, and with surgery, including the perioperative complications, about 9% over 2 years. This is if you have asymptomatic carotid narrowing. The benefit is much less, about 1% per year. And this is if you have symptoms, but the narrowing's less than 70%. So the big difference there. Symptoms on a high-grade stenosis is the indication for surgery. Now, currently we have another option. This is showing a carotid plaque. It's a diagram, not a photograph. There's a catheter in here. A distal protection device has been deployed, and I'll show you an actual picture of one of those in a minute. And then here a stent is placed. So this is another possible procedure. You can do angioplasty and stenting rather than surgery. So here's the stent. It looks like a chain link fence. You know, to those who know about coronary stents, this is a bare metal stent. It's a bigger artery than the coronary artery, so they don't have to use the drug-coated, drug-eluting stents. And this is the distal embolism protection device. It looks like a little umbrella. So you put it north of where you're going to be doing the procedure so that if any little clot goes up, it gets caught in this parachute and then it can be pulled out. I have the clinical trial here. I just want to make a couple of points. If you look at the main endpoint was stroke, heart attack, or death. The two were about equivalent. This is carotid endarterectomy surgery versus carotid artery stenting. And if you look at stroke or death, though, surgery is still better. So stenting, you have a lower risk of heart attack, but the risk of stroke is a little bit higher. So I think for a person who's a good candidate for surgery, surgery would still probably be the way we would go. The other point, which I don't know if you can see this or not, but in the middle curve, age was a factor. The older people, over 70, did better with surgery. The younger people did better with stenting. That was kind of a surprise to most of us. We thought older people would do better without a surgical procedure, but it may be that older people have more delicate arteries and that putting these catheters up causes more complications. So these days we're still doing both. We do the stenting for high-risk patients, and I can talk about that if there's a question. So I want to talk a little bit about emboli from the heart, and this is just showing that atrial fibrillation is the most common one. But there are others. If you have a prosthetic heart valve, or you have rheumatic heart disease, or a very large heart attack where the ventricle of the heart is not pumping well, those are also risk factors for emboli. And this is an old picture from autopsy lab showing mitral stenosis from rheumatic heart disease and a great big clot sitting in the left atrium of the heart. So it's not hard to imagine how a bit of that clot could break off and then go to the brain. So these are 5 different clinical trials where basically placebo in green is being compared against warfarin, or for those of you who know it by the brand name Coumadin. It's an anticoagulant, a blood thinner. So clearly you can prevent stroke in people with atrial fib. And that index patient I showed you was not on it. And this is a way of, yes?
Do you feel that all atrial fibrillation should be treated with Coumadin?
Okay. Well,
Medication?
okay, so the question was, do we treat all comers with atrial fibrillation? And the answer to that is on this slide, but it's a little bit complicated. But we have an algorithm called CHADS-2 that stratifies, kind of like the ABCD2 score for TIA. Your cardiologist would know all about this. And if your CHADS-2 is 0, you don't need to be treated with warfarin. If your CHADS-2 is 2 or more, generally we recommend it. If your CHADS-2 is 1, we're not sure. And if you want to see how the CHADS score is come up with, it's up here. So unfortunately, age is a big risk factor. If you're over 75, you're at increased risk. Hypertension, heart failure, diabetes, and any history of stroke or TIA. Okay, now I wanted to mention that just in the past year, we've had some new drugs come on the market that are anticoagulants that will be competition for warfarin. Everybody is afraid of warfarin, both patients and doctors. So that was the clotting cascade. I think I'll skip that. But we have a direct thrombin inhibitor called dabigatran or Pradaxa. And we have factor 10A inhibitors. There are two of them. Rivaroxaban is on the market now. Apixaban is not yet, but will be, I think. And these drugs, all the three drugs in blue, have in common that they have a predictable effect on coagulation. So you don't have to, if you're on warfarin, you have to go in for blood tests every couple of weeks, and you have to watch your diet. And you have to keep adjusting the dose up and down, and there are lots of drug interactions. These drugs all have a predictable effect on clotting, so you take a standard dose. You don't have to do all the blood testing. You don't have to watch your diet. There are very few drug interactions. The main problem is kidney failure. They accumulate in kidney failure. And this is just showing you that dabigatran at the higher dose was better than warfarin. It actually prevented more strokes than warfarin. And the bleeding risks were comparable, but hemorrhagic stroke was a lot less. So for some reason, bleeding in the brain was way less than with warfarin. Bleeding anywhere was about the same, though trending less. And there was a lower dose tested. I personally would have liked to see that lower dose, but the FDA chose to approve only the higher dose. That's the curve. Rivaroxaban doesn't look quite as good as that. It's more equivalent to warfarin rather than superior to warfarin. But apixaban may be superior. Apixaban is not yet on the market. So the last little topic before I stop is antiplatelet therapy. And the most common antiplatelet drug is aspirin. You all know about aspirin, right? In fact, I find most people have heard of this cyclooxygenase or COX enzyme. People know about COX-1 and COX-2. COX-2 inhibitors were arthritis drugs that were really wonderful. There's only one of them left on the market called Celebrex. The other two were taken off the market because they seem to cause heart attacks. So if you take a pure COX-2, it seems to actually make you higher risk. And the reasons for that are not completely understood. But I would say if you're on Celebrex, you should probably take a baby aspirin also. Another thing to know is that where aspirin works on this enzyme, it competes against our other arthritis medicines. So if you take an ibuprofen, Advil, or Aleve, or any of those, it can interfere with your aspirin. So make sure you take your aspirin first thing in the morning and that you wait till later in the day to take your arthritis pill. Up here are 4 names of drugs that block at a different receptor called the ADP receptor. The one that most people know about is clopidogrel, which goes under the trade name Plavix. Ticlopidine or Ticlid is not used very much anymore because it had a lot of toxicity. These two are new drugs, and they're used mainly in heart disease. Up here is dipridamole, which is used in conjunction with aspirin. It has a weak antiplatelet mechanism, but it also is a vasodilator, and some of its benefit may come from that. So, how much good can you do with aspirin? This is an old slide from 1994, when the only antiplatelet drug was aspirin, pretty much. And it's looking at different groups of patients when you could do studies with aspirin versus nothing. We couldn't do that now. And you see in people that have had a stroke or TIA, there's a benefit of aspirin here that's on the order of 20%, 22%. So 3/4 of the time you're going to fail with aspirin. That's one of the lessons. It's not 100% effective. So can we do better than aspirin? And I could easily give an hour talk on the different trials with different antiplatelet agents. There are 2 trials that say that aspirin plus dipridamole goes under the trade name Agrinox in the United States, that Agrinox is better than aspirin. And I used a lot of Agrinox in my time. There's one study comparing clopidogrel, Plavix, to aspirin. It was only a little bit better than aspirin. I have a slide of that I'm going to show. Well, lo and behold, the makers of Agronox, aspirin dipridamole, did a trial comparing it to Plavix, to clopidogrel, called the PROFESS trial. We were in that. Everybody assumed Agronox would win, and it didn't. The two drugs were equal. I'll show you that slide. The other thing I get asked all the time is, what about aspirin and clopidogrel, aspirin plus Plavix? If any of you have been to a heart doctor, a lot of people are on combined antiplatelet therapy for heart attack. And in the heart literature, it has benefit. In the stroke literature, 3 different trials, it hasn't been proved to have additional benefit. And it causes more bleeding. So we don't recommend aspirin and Plavix routinely. Now, I say routinely. I make exceptions to that sometimes. So just the 2 clinical trial slides. This is the one comparing aspirin and clopidogrel. And, you know, I've hinted, I mean, a lot of the interpretation of this is statistics. The 8.7% is a relative risk reduction. If you want the absolute risk reduction, it's 5.8 minus 5.3. It's about 0.5%. So that means you have to treat 200 people for a year to prevent 1 stroke, heart attack, or death. So it's not much better than aspirin. This happened to be full dose aspirin, 325 milligrams. This is the one comparing clopidogrel Plavix against aspirin and dipridamole. You can see the 2 curves could be superimposed. They're identical. So what's new in the world of antiplatelet therapy? There's a problem with Plavix that we've discovered, that it has an interaction with proton pump inhibitors. Those are drugs like Prilosec, Nexium, Protonix that are used for the stomach. They interfere with Plavix. They may also interfere a little bit with aspirin. So that's one problem. It's not clear whether that makes a difference clinically. There are also some genetics. The CYP2C19 system has various mutations in it, some of which have a loss of function for the effect of Plavix. So if you have one of those mutations, you may not respond to Plavix. How common is it? Well, it's 2% in Caucasians, 4% in African Americans, 14% in Asians. So it's not that rare. Does it make a difference? In some trials it does. In some of the coronary trials particularly, if you have one of these mutations, your risk of having another heart attack on standard treatment is higher. You could also do platelet resistance testing, and the problem with that is there are 3 or 4 different tests on the market. The one we use at Vanderbilt is called Verify Now, because we can get it back the same day, but they don't all agree with each other. So some of you have heard on the radio some ads that Vanderbilt does, that we do personalized medicine at Vanderbilt. We tailor our treatment to your DNA, and we do that in cancer treatment, and we do it in stroke and heart attack treatment, and most recently we do it with statin therapy. So you can do genetic tests to see if people are going to respond. Do we do it on everybody? To be honest, we don't. The genetic test is expensive, and it takes about a week to come back. But they do it in the heart lab at Vanderbilt on every patient. And we're starting to do some variety of testing, either this one or genetic testing on everybody that gets an interventional stroke treatment. Okay, so this is my last slide. Ischemic stroke's a major cause of disability and mortality in the US. Most strokes, way more than half, could be prevented just by risk factor treatment and lifestyle modification. And that includes diet, exercise, smoking cessation, blood pressure treatment, diabetes treatment, and lipid lowering treatment. Anticoagulation for people that have atrial fibrillation and related heart disorders. Those people that have a carotid stenosis, especially more than 70%, and with symptoms, have a carotid surgery or stenting. Everyone else gets antiplatelet therapy, and usually that, I mean, in our hands, usually aspirin is first line. If they fail aspirin, we may go to clopidogrel or Agrinox, but we're using Agrinox less. And if you have a warning sign of stroke, one of those 5 TIA symptoms I mentioned, don't call your doctor. Don't, you know, if you call your doctor, you're likely to get an appointment for Monday, and if you call your insurance company hotline, they'll say make an appointment to see your doctor, your PCP. So don't do that. Call 911. Go to the hospital. This is just a schematic of, you know, this slide was put out by the National Stroke Association in 1995. It's a bit outdated because it said that by 2005 we'd be doing this, that everybody would call 911, everybody would go to a hospital that was stroke ready, that we'd be giving neuroprotective drugs en route to the hospital. We don't have those yet. That we do some kind of a brain image, we do clot dissolving and neuroprotective treatment, nerve growth stimulants, computer-assisted rehab therapies, and everybody would recover. We're not quite there yet. Yes, ma'am.
Okay, for stroke-ready hospitals, Vanderbilt
You know, what?
Do you have a symptom of stroke? Will they take you automatically? I don't know. Do they take you to the nearest hospital?
You know,
I want to go to Vanderbilt?
well, of course, I work at Vanderbilt. I would say, yes, Vanderbilt's the best, and you should go to Vanderbilt. In Middle Tennessee, we're actually very lucky. There are 6 stroke centers. I would doubt that there's any place in the country that has a higher density of stroke centers than Nashville and Middle Tennessee. They're Vanderbilt, Baptist, St. Thomas, Centennial, Skyline, and Middle Tennessee Medical Center. Those are the 6. And I think there are only about 11 or 12 in the whole state of Tennessee. Last I heard, there were none in West Tennessee. There are some in East Tennessee. So as far as what you do, you know, trauma's ahead of us. Level 1 trauma centers, you go to the nearest one regardless. And you know, if you're in Winchester, Tennessee, and you know, over an hour from Nashville, you still come straight here. If you have a stroke, it's not so clear because the Medicare rules say go to the nearest hospital. But I think we're coming to a time when we're going to get past that, and you can say, I want to go to a stroke center, and you'll go to the nearest stroke center. There will be stroke-ready hospitals that can evaluate the patient, do a CT scan, and then send the patient on, start the TPA drip, and send the patient on. And we're using telemedicine more. We're hooking up hospitals through telemedicine networks so that we can treat more people. I don't know who's next. I think you are.
What are the symptoms for atrial fib? Can I pick this up on my own?
Yeah, that's a good question. Atrial fibrillation means an irregular heartbeat. Some people notice it, and some people don't. If you feel your pulse, you can notice it. So it's probably worth doing that.
What is it that you notice?
You just notice that instead of la-dub, 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 it's you know, da-da, 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 it's irregular. It's a bunch of rapid beats, a pause. Now, you can't tell from feeling your pulse if it's truly AFib or if you're having occasional premature beats or something, which can be benign. But I think if you feel an irregular beat, you want to have your doctor do a heart monitor test. Yes, ma'am.
You mentioned surgery, and I am not clear on what kind of surgery do people have.
Well, I was mainly talking there about carotid artery surgery, opening up the carotid artery in the neck.
And that is not with a stent.
Well, there are 2 procedures. There's a surgical endarterectomy where they make an incision, open the artery, scrape out the lining. Some people put a bypass in while they're doing it. Some people do monitoring during it. There are a lot of different techniques. But basically, it's scraping out the artery. The other technique is to put a stent in. Yes?
What are the implications of chronic low platelets to risk of stroke?
The question was about chronic low platelets. Well, the main risk of low platelets is bleeding. So, you know, hemorrhagic stroke, it has to get very low usually before that's a problem, though.
Well, every time I have a test, it comes up in red, low platelets.
But, you know, how low? Is it?
I don't know.
Okay. Yes, ma'am.
Does your doctor pick up the potential, can your doctor tell them you're over 70% in your carotid?
You know, these are great questions. The question was about, can your doctor tell if you have a carotid narrowing of 70%? Your doctor can listen with a stethoscope and you hear what's called a bruit, which is a French word for noise. You hear turbulent flow. It's about 50 to 60% sensitive for picking up a narrowing. It also tends to go away when the narrowing gets the most severe. So if you really want to know, you have to do an ultrasound, you know, a carotid Doppler test. There are some companies that are doing screenings where they're doing large populations of people with Dopplers. You know, I'm not sure if that's justified because the data on asymptomatic patients is not all that good for surgery. So I think that's kind of another gray area, but if you're a high-risk patient or you've had a TIA, you should certainly have an ultrasound. The gentleman back there. Yes.
What are some of the possible treatments that
Okay, so the question was about sleep apnea and Vanderbilt treatments. We have 2 sleep centers, actually. One is in the Marriott Hotel here near the campus, and the other one is in Franklin in the Hyatt Hotel. But, I mean, generally, we send the patient to a sleep doctor. They see the person in the office. Then they decide if the overnight sleep study is worth doing. The treatment is mainly a breathing machine called CPAP, but there are some other treatments. A lot of people don't tolerate CPAP well. And I mean, the best thing I can say about the Vanderbilt Sleep Clinic is that they really try to work with people to find something that people can tolerate well. Yes, sir.
What about high platelet count, 750 to 800,000?
Right. So the question was, what about high platelet count? High platelet count can lead to the other kind of stroke, ischemic stroke. Again, like most people tolerate platelet counts in a fairly wide range, so you don't bleed into the brain until you're something like below 20,000. Normal is, I think, 150 to 400,000. If you get up around 1 million, you can literally start clogging arteries and cause a stroke that way. So high platelet counts are not good either. A little bit of aspirin goes a long way in that condition, though. It keeps the platelets from clumping together and causing trouble. Yes, ma'am.
How do you know the difference between a TIA and what is sometimes referred to, I think, as a type of headache? If you have
The question was the difference between a TIA and a type of headache, and I think what you mean is migraine.
migraine.
You know, some people with migraine have what's called an aura. Aura means a warning. And the aura can be tingling in one arm. It can be usually visual disturbances, most commonly. Occasionally, it's speech trouble. There was on the news about 6 months ago, there was a newscaster somewhere in the Northeast who just started speaking gibberish and turned out to be migraine. It's hard to tell, to be honest. I mean, there are some differences. Migraines tend to have positive phenomena. So in the visual system, it tends to be flashing lights, zigzag lines, whereas a TIA tends to be just loss of vision, not seeing. In migraine, it tends to be tingling in the arm. In a stroke, it tends to be numbness. But these differences are subtle, and I know I've treated at least 2 migraine patients with TPA. Better safe than sorry, I think. But you know, migraine patients tend to be younger. They tend to have recurrent episodes. Tends to be followed or accompanied by a severe throbbing headache. So there are some differences, but it gets into the art of the practice of medicine rather than the science. Lucia?
When you're talking aspirin, are you talking baby aspirin, 81 milligrams, or what?
Right, so that's a good question too. The question was about dosage of aspirin. You know, there are a lot of different clinical trials using aspirin, and they've used all different doses. And the bottom line is you really can't see a big difference between doses of aspirin. So I think baby aspirin most of the time is okay. Now, if you use a coated baby aspirin, there's some question. If you do those platelet function tests, some people will not have adequate platelet inhibition with a coated baby aspirin. So it should be a regular baby aspirin or a coated full adult aspirin, I would say. In the heart literature, they say for acute heart attack purposes, it needs to be at least 2 baby aspirin, 162 milligrams. But we haven't found that in stroke. Let's see, back there, the lady towards the back.
Aspirin in the morning or at night?
Well, do we recommend aspirin morning or night? Most people take it in the morning just because it's easier to remember and because you'll be eating food afterwards, so it's less likely to irritate your stomach. But the effect is long. You know, aspirin binds on the platelet and stays there for the life of the platelet, so it's a long-acting therapy. Yes?
What about hypothermia? Are they using any hypothermia in treatment?
Hypothermia is cooling people down. So there is an interest in using that in acute stroke. The best place where it's been shown to help people is in people that have a cardiac arrest and are in coma. It's been shown that hypothermia has a clear benefit there. So if you have a cardiac arrest and you get admitted to Vanderbilt to the cardiovascular ICU, they cool you down. In stroke, the results have been mixed, so we're not doing it routinely. In traumatic brain injury, it hasn't been shown effective. So I'd say it's still an area of research. Yes, ma'am.
About 40 years ago, a relative had a stroke, and she had to be put into a nursing center. And she had limited her intake of eggs because at that time they were saying, you know, that was bad for you, you've got too much cholesterol, this type of thing. So she had just stopped it. And there came about at the same time a publication that stated that if you had stroke, you needed albumin from eggs. So I was wondering if you have any research on this. A comment on food.
Well, albumin's in the white of the egg, so you can certainly have egg whites as much as you want. It's a good source of protein and it's healthy. As far as eggs, I mean, they do have a fair amount of cholesterol content, but they have other things that are healthy in them. So I think it's mixed. And I think if you want to know whether you can safely eat eggs, you should have your lipid profile done. You know, if you have a normal lipid profile, you can go ahead and eat eggs. Personally, I eat eggs 1 morning a week. There's certain foods that people don't know about that have a lot of egg yolks. I mean, that's a place to watch out. Key lime pie is one of the worst offenders. One of my favorite things. It's made from all egg yolks. Creme brulee, not so good either. You know, caffeine does have a little bit of blood pressure elevation, but there's been a lot of research in caffeine, and it's been hard to prove that it's harmful. I mean, there's one place is people who have cardiac arrhythmias that can trigger those. And there was one study in stroke that people who don't drink coffee, if they drank a potent coffee like a Starbucks, and they weren't used to it, that there was a higher risk of stroke in the 30 minutes after that. But in general, coffee use doesn't correlate very much. Yes? Aspirin and nosebleeds. It will make you more likely to, I mean, it's an antiplatelet agent. Nosebleeds, of course, there's some individual anatomy that controls that, but hypertension is another big risk factor for nosebleeds. So making sure your blood pressure is controlled is very important. If you have a nosebleed on a small dose of aspirin, I think you need to go see an ear, nose, and throat doctor, otolaryngologist, to see if it can be fixed, because I mean, it is a problem. Yes, ma'am.
I'm confused about the aspirin issue. If you don't have a problem with your heart, if you know of, the general population, should they take aspirin?
Yeah, you know, that's a question that I appreciate because I should have commented on it. I mentioned a lot about secondary stroke prevention, and I said I would talk about primary, but I didn't talk about primary antiplatelet therapy. The evidence in primary prevention is much less, but in men, there was a study called the American Physicians' Heart Study. It was done about 20 years ago, and it was physicians in their 40s and 50s, and they were given 1 aspirin every other day or placebo. And the bottom line is that it prevented heart attack. So as far as stroke went, there were more brain hemorrhages with aspirin, fewer ischemic strokes, no statistical difference. So men, middle-aged and older men, should probably take aspirin to prevent a heart attack. As far as women go, the Women's Health Initiative, which did a whole series of studies, there was a surprising finding, was published in 2005, and now the dose of aspirin in the Women's Health Initiative was 100 every other day. It's a dose we don't even have in the US, but roughly a baby aspirin every other day. And it was interesting to me that in the men's study, heart attack was more than 3 times more common than stroke in men in their 40s and 50s. In the Women's Health Initiative, the group 45 to 60 had more strokes than heart attacks. Women are different that way. Still less numbers than men total, but middle-aged women are at some risk of stroke, and the 100 of aspirin every other day was effective in preventing it, both middle-aged and elderly women. Now, I've been advised that we shouldn't make this a blanket recommendation, that you have to talk to your doctor about what your personal risk factors are with aspirin to decide if it's better for you. But if you have other risk factors, if you have diabetes, if you have any kind of heart condition, then you probably should be on a baby aspirin at least every other day. That's my opinion. That's not in the guidelines. Lottie.
I took baby aspirin every day or every second day, I don't remember. And all it did is just make me have more bruises all over my body, and I quit it right away. For that reason, it really made a tremendous difference.
With it, I think there are some people, especially women, who bruise very easily on either aspirin or Plavix. I mean, we don't need to do a platelet response test on them or a genetic test. We know that they respond if they're bruising all over. And, people that have had a stroke and complain of that, I tell them that means the medicine's doing its job. It's going to prevent you from having another stroke. But it's a real phenomenon. Yes? I really didn't explain that. I think it's a good question. She asked what's happening when you have a TIA. If we do MRI scans, which we do at Vanderbilt, if we admit somebody overnight with a TIA, we do an MRI scan. And about 1 in 3 will actually have a little stroke, very small stroke. So then we don't call it a TIA anymore. We change the diagnosis to stroke. But the other 2/3 don't. So what exactly is going on? It may be a clot that went up to the brain and then it broke up and moved on and didn't leave permanent damage. That's the leading theory. If there's a carotid blockage, it means that maybe that blockage got worse temporarily, or a little clot formed at the carotid plaque and then went up. There are probably more than one mechanism. But it means that there's not enough blood flow to a part of the brain temporarily, and then it opens up again. So I think it's about the time that I'm supposed to end. Is there any last questions? Come on up to the front.